Much for having me, Dee. This is so great, and I'm so glad that we're doing this. PCOS or polycystic ovary syndrome is one of the most, I think, misunderstood conditions, and is honestly very confusing. And I love, referring patients to you, and kind of just love what you're doing, because truthfully, the best management is through lifestyle, and eating well and staying active are really the core parts of that. But I think at the end of the day, you have to kind of understand the diagnosis first. So let's dive into that. As you mentioned, I am a reproductive endocrinologist and infertility specialist based out of Houston, at CCRM Fertility. What that basically means is that I'm an OBGYN that's done 3 extra years of training in reproductive hormones. And PCOS is a particular passion area for me, not only because it's so common among South Asian women, and so it just feels like a really personal topic for me and for our community, but I think I just also find it really kind of fascinating, I think, to take care of women that are going through this, because of the fact that it is kind of confusing. There's so much education and empowerment that we can do around this topic. So PCOS, to kind of start with some of the definition, and sort of debunking some of the common misconceptions. Most of us nowadays use the Rotterdam criteria. There are actually 3 sets of diagnostic criteria, which is part of what can be confusing for people. But this set of criteria encompasses the most people. So the nice thing is that you can catch the most people with this diagnostic criteria. And so to meet that definition, you have to have at least 2 out of 3 things. So the first is having menstrual cycles off of birth control that are irregular, meaning that they come outside of a fairly predictable 24 to 38 day window. And they typically will be anovulatory, meaning that somebody's not ovulating an egg in that cycle. Sometimes that can be a bit confusing. I've definitely had many patients over the years that actually had fairly regular cycles, but then when we got into the detective work and figuring out their diagnosis, it turned out that they were not ovulating. So we'll talk a little bit more about that later, but that's kind of the first criteria. Second criteria that would be applicable to all non-adolescent women would be actually an ultrasound, typically a vaginal ultrasound, where we actually look at the ovaries. And what we see there is a very typical appearance, starting with one big myth. It does not necessarily involve having cysts, quote unquote, on the ovaries. But what it means is that typically the ovaries might be a little bit bigger than would be expected for your age, or there's actually more eggs available month to month, again, than somebody that same age on average. And so the way that looks on ultrasound is that there's lots of little follicles, which are the little sacs that the eggs grow inside of. And so those are called cysts. It's kind of a misnomer. And so that's kind of what we expect to see. So anybody that is, like myself, somebody trained in ultrasound, can sort of do that with you and show you what that looks like. And then finally, you may experience symptoms or have blood work that suggests a higher than average level of hormones like testosterone. And that can show up with having severe cystic acne, having excess facial or body hair, or hair growth in places that women don't always get hair, like chin, sideburns, between the breasts. Sometimes it can even show up like male pattern baldness, or like hair loss, particularly at the temples and things like that. So it can show up in a variety of ways, and through blood work, as I mentioned. So those are kind of the 3 things. If you have 2 out of those 3, you have the diagnosis. And again, very difficult to diagnose when you're on birth control, because it really impacts pretty much all of these criteria. And so we'll talk a little bit more about birth control later, because I know that that's a very interesting kind of correlation there. We'll talk about what the relevance is, but that's really the main diagnostic stuff that we need to know.
Okay, cool. So you have to have 2 out of 3 of those things, the Rotterdam criteria. And so basically that means not everybody who has PCOS gets diagnosed with an ultrasound. Right?
That's correct. Yeah, it may not be necessary if you already have the other 2 criteria. That's true.
Got it. Interesting. Okay, cool. So once somebody is diagnosed with PCOS, what are the next steps for them?
Yeah. So, I think what that leads into, perfect segue, is that partly because there is this broad set of criteria, it also means that every woman that has PCOS is kind of unique. And I think that's what's frustrating for a lot of people, is that unfortunately finding the right management plan for you does involve a little bit of detective work to sort of sort out what your symptoms are, and what's actually, your pressing issues. So the way I like to think of it is kind of based off of a validated instrument that looked at women that have PCOS and said, hey, what are the most bothersome aspects of it that impact your quality of life? And there are 5 main areas that came out of that study that, sort of relate to PCOS. And I try to think of each of these 5 things when I'm working with women, because we're all at different phases of life. And so when I think about one woman over the course of her lifetime, at some points in her teens and 20s, some aspects might be problematic. When she's in her 30s, other aspects, and then beyond. And so those 5 areas areas. One is irregular bleeding. So again, when you have those irregular cycles, particularly if they come at completely unpredictably, or when they come, they could be very heavy at times. So, that's definitely one issue. Obviously, uncontrolled and frequent heavy bleeding can lead to anemia, and then can lead to fatigue and other problems. So that's definitely problematic and just inconvenient, among other things. As a result of not ovulating, it can also be a cause of infertility. So obviously for somebody that would like to get pregnant, that would be very frustrating. The weight issues that can come along with that, another huge component I know we're going to talk about in depth, but basically the main connection there is that PCOS does predispose women to becoming insulin resistant. Insulin is the hormone that deals with any sugar we get in our diet. So whether it's because we ate some sort of dessert, whether we ate some white rice, whether we had a soda or juice, all of those things have sugars in them. And so when we become resistant to insulin, our body finds it essentially more easy to turn that sugar we're consuming into fat. And so it kind of changes our metabolism essentially. And so weight gain, weight management, definitely the third component. Fourth component is the symptoms related to the testosterone level, particularly the hair growth, so unwanted hair. And then the fifth that oftentimes people don't understand or aren't aware of, I should say, is that PCOS is associated with a 3 to 5-fold increase in the rates of anxiety and depression. And so mental health and mood is the fifth domain, and that's super important. And obviously, I think, more and more recognition of the fact that it's kind of all interrelated. If you're struggling with all of these things, if you're having unpredictable cycles or infertility or, weight issues or whatever, you're then more likely to have anxiety just because of all of that, or depression. And so I think there's a lot of interrelation between all of these things. So these 5 domains are what I think about. And so when I'm meeting with somebody, I will sort of talk through these areas and say, hey, right now, what are the things that are bugging you? And then we come up with a management plan for that. Because there are women that have PCOS, but actually don't have the weight issues. And so maybe they have something else going on, and vice versa. So there's no one size fits all, is kind of, again, the frustrating piece. First step is making sure the diagnosis is right, because I see over and under diagnosis both. And then the second thing is figuring out which parts are problematic for you right now.
Got it. So can you repeat those 5? You said excessive bleeding, the weight management, mental health,
Yep.
and what were the other 2?
Infertility and the unwanted hair growth.
Okay. Got it. That's a great summary.
Yeah.
Okay, awesome. So let's say you get this diagnosis, you look at these kind of different areas. What are some of the treatment options for PCOS? I know that we can do medication, we can do lifestyle, we can do a combination. How do you decide what to recommend for a patient?
Yeah. Okay. So it kind of depends again, what somebody's looking for. So I think one of the big things is kind of, okay, are we going to try to be, first line would definitely be lifestyle. Okay. So let's talk about what that means. The studies have actually shown that there's not one particular diet that is the best for PCOS. I would basically say that healthy diets are generally better than unhealthy diets, which is a very simple way of thinking about it. And you and I were talking about this earlier. There is no magic thing. What we were saying earlier was, that sometimes people come in, they're like, okay, I've cut out all gluten and I've cut out all dairy and I'm still, having all of these symptoms. But sometimes it could be that the rest of the stuff that they actually are eating is not, that healthy. And so when we look at what we're eating, and, we're looking at diet, what I would say is that in general, a Mediterranean style diet or something kind of, derived from that philosophy is my personal recommendation. And what I always tell people is that doesn't mean how you cook the food. You could actually be eating almost exclusively South Asian food, but make it with that philosophy. And what that philosophy means is definitely being plant forward. So, lots of fresh fruits and vegetables, a diversity in that, the whole eat the rainbow thing, definitely real, because different types of vegetables have different micronutrients in them. And so it's really important to get that variety in our diet and that diversity of plant-based proteins, also super important. So plant forward, lots of fresh fruits and vegetables. Fruits are also fine, unless you're really struggling with borderline sugar control. Fruits are definitely a much better sugar, quote unquote, than any sort of processed sugar. I've had patients that told me that they don't eat fruit, but then they eat sugar-free Jell-O. That's not a good trade-off. So whole foods, real foods, avoiding processed food, avoiding packaged food and fast food. And then those sugars, though, can be problematic. So from that perspective, when we think about carbohydrates, focusing on whole grains rather than refined white flour products. So white rice, white pasta, white bread. And then when we think about animal products, if we are non-veg, then, trying to gear more towards fish and maybe lean poultry rather than red meat is probably advisable. And then side things, healthy fats are very important, not only for feeling full, but for us as women, because cholesterol is the building block for estrogen. And so you definitely need some healthy fat in your diet, even if you're trying to lose weight. Healthy fats are important. So that could come from things like avocados, nuts, nut butters, chia seeds, basil seeds, things like that. And so those are kind of the cores for me. Hydration, super important as well, and kind of watching your beverage intake, etc. So from the diet perspective, that's some of the keys. Physical activity, obviously you're the expert there, but it is important to stay physically active, and it's a balance. We'll talk about a little bit of that, more. There is sort of a belief system that sometimes people can actually push themselves too hard, and that's something that oftentimes my PCOS patients ask. But the majority of people that I see could use either changing up their routine or finding the right routine that works for them, that kind of maximizes the time that you put into it. It doesn't have to be something super onerous where you're working out, like 2 hours a day or something. So we can talk about that piece of it more. And then to me, sleep and stress management are the other parts of that. So, when we don't get enough sleep, it's very hard for our body to recover from the daily stresses of the day. It predisposes us to weight gain and bad eating choices. So, that's kind of part of it. And then, like I said, is kind of the mental health and mood piece of it, which is, again, super individual. You have to figure out what works for you based off of what you're experiencing, whether you get some bonus out of sleeping well and exercise, and that pretty much keeps you even keeled, whether you're in therapy, whether you have a buddy, that is going through this with you, or support group. There's, so many ways to manage that. Acupuncture is another that a lot of my patients use. So there are a lot of approaches to that, but, lifestyle is really the core. And so for somebody trying to kind of bring all of their symptoms under control, that's really the first step, because once you are able to do that, especially if you're off of birth control and we're trying to get cycles regular where you're actually ovulating, that helps fix a lot of the symptoms. Because if your weight is under control, your hormones are in balance, that keeps the balance between estrogens and hormones like testosterone in the right ratio. And so that helps reduce the symptoms of, that are related to that high testosterone level, like the unwanted hair, etc. And so also kind of takes away the symptoms we experience when we have a persistently low estrogen level, which is what happens if we're not actually ovulating. So as an adjunct to that, many times people will use birth control. And truthfully, the only downside to birth control, in my view, is when people are just put on birth control without understanding what's going on in the first place, or without getting the opportunity to try to fix it, through more natural means. And that's what I see a lot. People come in and say, maybe I wasn't even given a PCOS diagnosis. I was just told I had irregular cycles, and, I was having irregular bleeding, and I was a teenager, and it was uncomfortable, and I was just put on birth control. And so that's a missed opportunity. And that's really the main issue that I see as problematic with birth control. What birth control does is it gives you estrogen and progesterone. So it gives you the hormones that your ovaries would typically make. So it basically suppresses your own ovaries' drive to try to do something. So the downside to that is that you don't get a chance to track your cycle. So if you're curious of what's going on with your cycle, and let's say you're trying to live a super healthy lifestyle and you want to know, hey, am I ovulating on my own? You can't know that if you're on birth control. So that's probably the main downside. But otherwise, long-term birth control use reduces your risk of ovarian cancer, endometrial cancer, colon cancer, obviously is a great contraception. So, will improve some of these issues by, again, hormone balance. So reduce hair issues, hair loss, etc. So there's a lot of advantages to utilizing it.
Someone asked in the comments, are there any what are the effects of long-term birth control use for PCOS?
So the good news is that birth control, like I said, doesn't really have any long-term detriment to it. I would say that the main thing would be over time is, from a fertility perspective, sure, if you go on it when you're 15 and you come off when you're 40, your fertility is going to have changed in that much time. And I think sometimes people just, kind of think, well, oh, I keep having a regular cycle, when I'm on the birth control. And sometimes they're not aware of that nuance, that you can't really track your cycle when you're on birth control. And so then they'll come in and say, well, my cycle has been, regular for so long. And, now all of a sudden I came off of it and my cycle was irregular, or now I'm struggling with fertility issues. And so I think it just masks what's really going on with your cycle. That's really the main thing. In general, birth control is very safe. I saw a question pop by about,
DVT.
blood clots and stuff related to being on birth control. The risk of blood clots and complications related to being on birth control is far lower than the risk of pregnancy itself. So, it just depends on the situation and why you're on it. Obviously, there is a minority of women that don't feel great on birth control. Some of them might feel better if they switch to another brand or another formulation. But some people just really don't feel great on it. And that's totally fine. You don't have to be on it. But if you are and you're feeling great on it, aside from, like I said, keeping track of your fertility and thinking about that as relates to age, no long-term side effects.
Yeah. Okay. So there are a lot of questions about going off the pill. So what happens when you go off the pill, when you have PCOS? What does that process look like? And what do you recommend to do that and manage things? Because I've heard.
Yeah. Okay. So that's a big transition. And I think, similar or related question, a lot of people are asking, when you're on the pill, is there a downside to not having your cycle come? And so, when you're on the pill, basically you can either take it cyclically, meaning that you take that off week or off, window of 4 days and have a bleed. And that's really not, again, a real period. That's what we call a withdrawal bleed because you were on hormones and now you're off of it. And so your uterine lining sheds. Or you can take it continuously where you just keep going on the active pills and don't have a period. Doesn't matter medically. There's no reason to have a period. Important tidbit. The only reason that birth control even had that off week was because initially when birth control was being developed, the idea or the hope was that the Catholic Church would approve it. And the idea was that if there was a period and it kind of seemed more natural, that perhaps the Catholic Church would approve contraception. Didn't happen that way anyway. So the rest of us have just suffered under that misconception because of this attempt to get the church to approve it, which, like I said, didn't happen anyway. So that's important. From a medical perspective, it has been known since the beginning that there's no need for that. But that, is just if somebody likes to have their period, basically. Now, when you come off of it, there is for all people, coming off of birth control, a window of kind of recovery of your cycle, like whatever, it's going to go back to whatever it was going to be. And that's pretty variable from person to person. Some people, they come off of birth control and boom, they are right back to where they would have been otherwise. Some people, and I would say, especially if you've been on long-term continuous therapy. So, let's say you have been on for 15, 20 years and you've been taking it and having, barely any periods, it may take a little bit longer for your cycle to bounce back. And so what happens is that when you're on birth control, as I mentioned, it kind of keeps your hormones a little bit more in balance. So it kind of does some stuff inside of the body. It's a little bit more scientific. I won't get into the details, but it kind of artificially keeps that testosterone level low. And like I said, it's providing that estrogen. So again, that estrogen to testosterone ratio is a little bit more balanced. So once you come off of it, if you don't start ovulating again, on your own at that point, then over time, you're going to start to see this predominance of testosterone relative to your estrogen because it's not being made in sufficient quantity by the ovaries. And so you might start to see a resurgence of symptoms, acne, hair growth, all of that. And oftentimes with this persistently low estrogen level, you're kind of essentially in a very long premenstrual syndrome, which is, what we have in that time is our dropping estrogen levels. And so that, a lot of times people will describe as, kind of crankiness, cravings, things like that. And you're basically stuck in this ongoing premenstrual feeling, which is just not great. And so, that is what some women experience when they come off of it, until their cycles regulate. And so I would say that if your cycle is going to resume and become ovulatory based off of your lifestyle or whatever else, usually that will happen within 3 to 6 months. And if you're sexually active with an opposite sex partner at that, during that window, super important to be using some sort of barrier contraceptive because it's really difficult to track your ovulation for most women, in that window of time. And so, I wouldn't want you to take a chance there and have an unplanned pregnancy. So I think that's super important. And so for people that are coming off of it with the desire to get pregnant, I usually like to suggest coming off of birth control 3 to 6 months prior to when you would like to be. Sorry about that. Prior to when you would like to be pregnant, so that you have that window of time to potentially track your cycle, kind of get a feel for what's going on. Now see if you can establish your ovulation pattern again. And then if not, you have that time to then seek care and kind of get some attention for why you're not ovulating and what you can do to potentially get that to happen.
Got it. So it sounds like the 3 to 6 months after you stop birth control are a little bit unpredictable with your body and the symptoms, but after some time your things kind of restabilize, is what you're saying?
Yeah, I mean, that's how it's meant to happen.
Yeah. Somebody actually asked a question too, and I've heard this, and I don't know if it's true, that you can develop PCOS if you go off birth control, like a
No, I mean, that
post-menopausal
would basically mean
PCOS.
that you had it this whole time, but that the birth control was masking it. So when you're on birth control, you'll have either no periods if you're taking continuously, or you'll have regular cycles. So that criteria you wouldn't have
Yeah.
because of what it does to your hormone levels. It reduces a lot of the symptoms. And even if you did have an ultrasound, when you're on birth control temporarily, especially over the long haul, temporarily, it makes your ovaries look smaller and less active. So it will even oftentimes kind of make them look non-polycystic. And so you really can't judge that when somebody's on birth control. So yeah, you wouldn't get it like suddenly. You don't develop it later. If you have it,
Yeah.
you have it your entire life basically. But sometimes the symptoms will show up later. And then sometimes, some of the symptoms are kept in control by our lifestyle. And so a lot of times I do see, girls and women that perhaps, they're going off to college and then they gain some weight, lifestyle changes. Maybe they're not at home and eating home cooking, and now they're eating all this food. And then, symptoms kind of creep up that way, like their lifestyle changes. And so all of a sudden, boom, maybe they never had the symptoms before, but it shows up that way. But again, they had it the whole time. It was just that it was actually under control with their lifestyle prior to that point.
Got it. Got it. Interesting. Okay. So I'm just going through the questions that are coming in. So
Yeah.
what is considered too long to go without a period from a health
So it
perspective?
depends. So if you're on birth control, no such thing, because
Yeah.
basically what's happening is that the hormones are kind of protecting all of your reproductive organs. So there's really no interval that's too long. For example, if you have an IUD, an intrauterine device, the kind that releases progesterone, many women become completely without periods, or what we call amenorrheic, like no period at all. And that's totally fine. When you're not on any sort of, when you're not pregnant, when you're not breastfeeding, when you're not on birth control, however, it's typically recommended to have a period every 3 months or so. And the reason for that is that basically, I've said a couple times that women with PCOS often are not growing eggs actively. And so their estrogen level isn't going super high, but all of those little follicles, little sacs that the eggs grow inside of, are making some estrogen. And so cumulatively, there's all of this estrogen exposure. And without progesterone, which comes after an ovulation, that's the hormone that kind of stabilizes the lining of the uterus and kind of gets it to shed and kind of get a period going. And so essentially what happens is if you have what we call unopposed estrogen exposure, meaning that there's all of this estrogen for months to years at a time, then eventually the lining of the uterus can build up precancerous and cancerous cells. So that's the danger. So when people come in and they say, hey, I haven't been on birth control or anything, but I have PCOS and I haven't had my period in 5 years, then I have to test them to make sure that in that window of time, they haven't developed any of those changes. So that's really the risk that I always tell my patients that I want you to be aware of, during that window. So every 3 months, if you're not pregnant, breastfeeding, or on birth control.
Okay, got it. And the risk is really because the uterine lining is not shedding regularly. It's kind of building up.
Exactly.
Okay, interesting.
Yeah.
So is PCOS lifelong? How do
Uh,
you
ye-
know? How do you know when you've successfully sort of reversed your PCOS, as they say?
Yeah. So unfortunately, it is lifelong. There's not a cure for it. But, what the relevance of that kind of goes back to those 5 domains of symptoms that we were talking about. So, in my view, if you basically have it, at bay and you're not experiencing troublesome symptoms, then you've kind of kept it under control, basically. And so, however that is, whether it's through, lifestyle stuff, whether it's through pharmaceutical approaches, a combination of the two, as long as you're not having symptoms from it and you feel kind of in control of managing it, then that's how I would say you have it under control, basically. And I think a lot of times with women's health issues, I feel like there's this stigma or this burden to say, like, I've cured it, I've gotten rid of it, or I'm doing something about it, or I'm reluctant to take treatment for it. But at the end of the day, like anything else, if you had high blood pressure, I hope that you would take medication. I mean, you want to live a healthy lifestyle, but if that's not enough, that I hope that you would take the medication to solve the issue. And same thing for this, whatever you need. Again, on top of what we've talked about before, I'm seeing a lot of questions come by about metformin. We could talk about that, but for specific things, there are other things that we might add to the equation. So for people that are having hair issues, we might add extra medications to reduce hair growth, et cetera, on top of what we've talked about before. And so there are extra things that we can add to the equation if lifestyle isn't sufficient.
Got it. Got it. Okay, so it's not something you can officially reverse. Like, there's no criteria of like you are
Yeah.
PCOS free, but it's more of your PCOS is well managed at this point.
Yeah, it's subjective.
Yeah. Yeah, I mean, I'm pretty careful with our language. We have a lot of clients, of course, who manage their PCOS, but I don't know if I should be saying reverse officially PCOS, or just generally manage. So that's good to know.
Yeah. I think manage is would be the right
Manage,
term.
yeah. So let's talk about metformin since it's kind of coming up.
Yeah.
What are your thoughts? Is it something that you recommend for patients? How do you make the decision to do metformin versus lifestyle only or a
Right.
combo?
Yeah. Okay, great. So, metformin is one of my favorite things to talk about because I see it so misused. So oftentimes people are given a diagnosis of PCOS and barely explain anything about PCOS, not said anything about lifestyle, and then just given a prescription for metformin. I'm sure you see that all of the time too. And it's really
Yeah.
annoying because actually what the studies show is that metformin by itself does nothing. Okay. So if you get a diagnosis of PCOS tomorrow or yesterday, and you start metformin and you don't change anything else, it's not going to do anything. That's what's been demonstrated in the studies. And so what it is, metformin, often people think of like, oh, isn't that a medication for diabetes? It is. It is a insulin sensitizer. So it basically helps the body to again become sensitive to insulin, which is the hormone we talked about before that deals with sugar that comes into our diet. So where I think it's most useful is basically for helping women that are looking like they're at risk for developing prediabetes or diabetes, essentially. And for some of those women, it can really assist with weight loss. And so, in that instance, I will usually check when I make the diagnosis or inherit a patient, I will usually check, at the minimum, a hemoglobin A1C, which is a blood test that gives you an idea of where your sugar levels have been living over the past 3 months. And so if that's starting to veer into the prediabetes range or definitely into the diabetes range, then we can use metformin to kind of help. I've had a number of patients over the years that will say that they're only able to lose weight when they're on metformin, even with their healthy lifestyle choices, and that's totally fine. If that helps, and that's been your experience, that's great. There's no harm per se to taking it. I would say that the main downside is that many people that do take it experience GI side effects like nausea, vomiting, diarrhea, and so we have to be careful about that. So again, no point in just starting it and potentially having side effects if you're not also going to be working with D or something else, to kind of actually make the lifestyle changes, because it really won't have an impact. For me, if your sugar levels are totally normal, and maybe especially if weight is not a super big issue for you, then I don't necessarily think that it needs to be prescribed. A lot of people think that PCOS equals being on metformin. I definitely don't believe that. And there's no guidelines to necessarily support that.
Yeah.
The inositols that a lot of people are asking about as well actually are more of a supplement rather than a medication, but they have some similar effects in terms of potentially improving glycemic or blood sugar control, and also similarly to metformin can help cycles to become regular again. Now, metformin is not super great at that. When that's been studied in very large randomized controlled trials, metformin alone helped people resume spontaneous ovulation about 7% of the time, something very low number, 11%, something very low. And so it's not super effective just for that purpose. Inositol still lacking in big studies, but I would say the data is promising, and definitely for my patients that are looking for kind of that non-birth control, inositol, natural approach, I definitely will recommend inositols to them. When it comes to vitamins and supplements in this country, they're not FDA regulated. And so I have to be really thoughtful about where I would recommend somebody to buy them from. There are a lot of good places to get it from. I don't have, I wouldn't say that there are bad options, but typically what I would recommend is that somebody, look at the manufacturing company. The places that I recommend, I won't drop names specifically here, but what I do recommend is that those places do third-party verification of their product. And what that means is that there are actual other third-party companies that will verify products, meaning that they will test batches of pills to make sure that these pills are actually reliable pill to pill, if they don't have contaminants, other stuff like that. So look for some sort of marking on that. It might say something like NSF or something else like that. And the dosage and all of that really depends on how it's formulated. It can actually be made in a variety of different ways. So there's not just one particular dosage there. It really depends. So you probably have to talk to your physician about that. But, for example, like I said, different places make it in different ways, and it will usually give you, some starting point for that product.
Got it. So do you provide inositol like guidelines for your patients?
I do. Yeah.
Okay.
That's part of, kind of part of the discussion point. Mhm.
Got it. Okay. And are there any other supplements that you recommend?
So I think after that, it kind of really depends on the situation. And there are a lot of supplements that people will talk about in relation to PCOS. That's probably the main one that I discuss in most detail. Unfortunately, when it comes to supplements, there's just not great data on a lot of this in the US. Some of my collaborators in the PCOS world have a lot more kind of detailed blogs and stuff on that topic. So I will say I do a lot of collaboration with somebody named Amy Medling. Her moniker is the PCOS diva, and yeah, you may know her. And she has a bunch of blogs about supplements and sort of talking about the symptoms that they're best in terms of impacting. So oftentimes, if people really want to get into the nitty gritty, then I'll refer that way. I'm also board certified in lifestyle medicine, and the philosophy of the American Board of Lifestyle Medicine is not so much about kind of like popping a million supplements, but really again trying to get most of that through a healthy diet, and then truthfully kind of seeing, okay, yes, if there are additional symptoms, perhaps there could be something appropriate, but with the paucity of data, I kind of usually will stop at the inositol point.
Got it. Okay, that makes sense. And then what are your
Yeah.
thoughts on kind of integrative or functional medicine practitioners and going to them for PCOS questions?
Yeah. I would say I don't have a problem with it. I work with a lot of patients that are believers in that. I don't think there's just not enough data to sort of suggest that going that granular and testing your levels of 50,000 things and trying to again take all of these pills, to me it's a little bit lacking in data. And what I see a lot is that people will go to a functional medicine provider and pay out of pocket for thousands of dollars of tests and all of these supplements. And it's kind of like a money making scheme. I mean, obviously, if I made my own vitamins and I was making thousands of dollars by recommending them, then, that's kind of like a kickback thing, right? So
Totally, yeah.
I always tell people to be smart about that. Like, before you invest all of this money, before you start buying supplements from somebody directly, that's, I think, something to think about, right? What is their, what is their agenda
What
and
is
what
their
do they get out of it?
affiliation? Yeah.
I don't have any particular company that I get a kickback from when I refer to for vitamins or supplements. So, that's kind of my take on it. But there's really just not any data to suggest that we need to be checking all of these individual levels. And ultimately, again, it's pretty clear with supplements that you are much better off by getting the stuff in your food. Well, you can't eat a food that is pure zinc, so if you're going to eat that, you're going to get something that's high in zinc. It's probably something that's healthy, again, would fall in that diverse eat the rainbow philosophy, and probably has some other good stuff in it too. So I think that's kind of how I view it, truthfully.
Yeah. No, that makes sense. So a couple of people in the chat box are asking about dosage for inositol. I don't know if that's something you can answer on an individualized basis, but any general recommendations?
Well, I know I just said before that I don't usually or I wasn't going to necessarily drop a name, but for
Yeah.
example, I will say personally, for most of my patients, the company that I work with the most closely and have kind of vetted myself is a company called Theralogix, and their product is called Ovasitol, which a lot of people have referred to it as such in the comments. That's like their brand name for the product. The Ovasitol comes in a powder form, and basically you kind of like put that into your water bottle and mix it up, and you do that 2 times a day. And so that's a sufficient dosage. There are, again, other formulations of it out there, but the Ovasitol is the one that I work with a lot, and that's kind of how that's utilized.
Got it. That makes sense. Okay. Cool. So there's a lot of questions on dairy and gluten consumption. So I actually have a whole blog post on this. I will send it out after this, but what are your thoughts? And I can also.
Yeah, so I think we agree on that. So, what I would say about dairy and gluten is that it is not an absolute one-to-one that every woman that has PCOS has sensitivities to dairy and or gluten. And so, truthfully, when it comes to, let's say somebody is trying to improve their diet, et cetera, I would say, like, if you're really going to get into it, you might consider keeping a food diary for a week. Sometimes people are like, oh, I think I'm eating healthy, but then, you're not realizing, what actually is all the things that you're going in, that are going into your mouth. And so, when it comes to it, when I tell people to keep a food diary, it's also like, what are you eating? what are you drinking, like everything that's going into your mouth, and then how are you feeling afterwards. And so, I tell people, sure, if you have a glass of milk or an ice cream or whatever, and then, shortly thereafter you feel bloated and super uncomfortable, okay, maybe you have a dairy sensitivity, and then you probably should cut back on dairy. Same thing with gluten. But if you eat those things and don't really have any symptoms, then you're probably fine. Obviously, in this case, the confounder is that a lot of things that have gluten are those refined white flour products. So those are just bad in general for pretty much everybody. So you want to kind of keep your consumption of that moderate to minimal, anyways. But in terms of going crazy and being completely extreme on that, I think it's only helpful if you really have symptoms that you notice, or if you trial it for a while and you're like, wow, I feel so much better, or I've lost weight, then great. If you're curious about it, you can experiment with it. But if you do that for a couple weeks and you're not noticing any change, then you may not need to be that strict. So, I think it's very, very individual. And I know plenty of women that have PCOS that eat dairy, and the recommendations there is for full fat dairy. If you're consuming, generally a little bit healthier, gives you more kind of satisfaction than like low fat or skim dairy. It's also more processed if it's lower fat. So, small amounts of full fat yogurt. I know plenty of women that are PCOS that have PCOS that do great with that. And so, that can be appropriate.
Totally. We have a mix of clients. Some prefer to be dairy free and gluten free just because they feel better. But the majority eat gluten and dairy, and they feel just fine. So generally, when you see blanket nutrition advice that says you have to cut out a major food group and it's very specific like that, it's not applicable to a broad population, because there's really no one size fits all approach. Every single human body is different.
Absolutely.
So there's a lot of questions about workouts with PCOS. So I can answer that. And then if there's anything for you to add, feel free. But when it comes to PCOS, strength training, lifting weights has been shown to really help improve insulin resistance. So particularly if you do have signs of insulin resistance with your PCOS, strength training can really help with that. High intensity HIIT workouts can oftentimes stress your body out, drive cortisol, stress hormones up. So for some people, they aren't ideal for PCOS. But again, there's really no one size fits all approach with this. I have some clients who love doing high intensity HIIT workouts, and they do just fine. While others prefer the slow weighted workouts. So again, no really one size fits all approach. In general, lifting weights does help. But the best workout plan is honestly going to be the one you can stick to, right? I would rather you do the workout that you enjoy, that you can stick to, that you can sustain for a long time, than one that's super, super intense. You could only stick to it for a month and then you fall off the wagon.
100% agree. Love that. I think a lot of people come in and they're like, oh, I heard that if you work out too hard with PCOS, that it can be a problem. And sometimes those people are barely doing anything. So I'm like, no, you need to do a little bit more than you're doing.
Yeah.
But it's kind of a balance. And I would definitely say, seek expert advice if you're not sure. To me, for most people that are kind of like, yes, they're pushing themselves too hard, driving up their adrenal hormones, their stress hormones, those are my patients that are, going spinning twice a day and, are really just like every day and like just really, really, really pushing themselves, or are doing like 2-hour HIIT workouts every day. You kind of really have to reach a pretty elite level, I think, to really kind of push yourself into that range. I think if you're doing, even HIIT style workouts a couple times a week, you're probably fine. If you're eating sufficiently to balance that out also, that's kind of the other thing. If you don't eat well, then you don't have as much reserve. Your body does go into a stress, sensation earlier. So yeah, I agree though. It's totally different from person to person, and you kind of have to experiment with what makes you feel best.
Yeah. But in addition to just, formal workouts, I would also prioritize movement in general, especially during COVID when we're all sitting at home on our butts all day. We're not getting up, going to the office, walking around. Our general movement and activity levels are significantly decreased. So we do have to be a little bit more active about getting steps in. That's why I think, having a step goal we give our clients step goals every day that are realistic to where they're at and what they can hit. But I think just being aware of how many steps you're getting in a day, trying to increase that slightly over time can be really beneficial here too. So moving on, there are a lot of questions about PCOS and pregnancy, as well as PCOS and diabetes. So can you talk a little bit about PCOS and fertility and maybe what you guys do at CCRM Fertility?
Yeah, sure. So from that perspective, so, as I mentioned, if somebody's off of birth control, they're trying to manage their PCOS, they're not ovulating, then obviously if you're not releasing an egg, you can't get pregnant. And so the key part of, fertility is essentially helping somebody to ovulate. And so the lifestyle part we've kind of talked about a lot already. That's kind of the first line. If that is, not doing the trick, then basically we start with medications to induce ovulation. Sometimes a lot of patients will come in having been on Clomid or clomiphene citrate before. Actually, a very large multi-center randomized control trial published now, more than 5 years ago, showed that letrozole is a better medication for most women that have PCOS. And so that's actually the medication I start with. And so oftentimes people are surprised by that. But I'm actually myself disappointed in how many physicians out there in the community seem to be unaware that that's kind of the first line medication. The nice thing about it is that letrozole is better tolerated, less side effects than Clomid too. So it's kind of a fairly benign medication. And the good news is that you only take it for 5 days in the cycle. So what it does is it tries to help stimulate the ovary to actually grow one of those eggs to maturity. So it kind of augments the signal that the brain is trying to send to get that egg to grow. So, that's kind of the treatment that we start off with. Obviously, once you're actually actively trying to get pregnant, there are additional things that I would do. Double check, your sugar levels, your thyroid levels, your vitamin D levels. So there's a whole bevy of things that I would do as part of preconception care. But in terms of actually sparking, something to happen, then that would be the first step. And that could easily just be combined with, timed intercourse at home if you have a male partner, with a normal semen analysis. But I think the thing to realize is that, the chances of getting pregnant month to month. So at that point, you're basically trying to recreate a spontaneous ovulation, and the success rate's there. If you're in your 20s or early 30s, month to month, that's coming close to about a 20% chance per month. By the time you turn 40, that's probably 5 to 10% chance per month, with a miscarriage rate that's going up. And so, you kind of have to keep that in mind. There are a lot of misconceptions around, oh, do you have an extended window of fertility when you have PCOS because you have more eggs? No, you don't, because unfortunately, as you get older, those eggs are going to continue to become abnormal just by virtue of age as well. And so if you are on this less aggressive side of the treatment spectrum and you're just, trying to release 1 or 2 eggs every month, if you're 42, most of those are going to be abnormal and unlikely to result in pregnancy. On the other hand, let's say you try that and you are moving through kind of treatment options and you end up doing IVF or in vitro fertilization. The success rates there will be a lot higher. It also depends on other factors, obviously, in your case. But there it can be a little bit beneficial in the sense that you might get more eggs and therefore have more healthy embryos to work with. And so it could be a little bit helpful there, to have the PCOS. I think is what some of research, including some of my own, has demonstrated. So that I think is kind of the thing. So when people say, oh, if I have PCOS, am I going to need to do IVF? Not necessarily if you are family building at a young age. And by that, I mean, through your mid 30s. And if, and by that, obviously there are exceptions to that. Sometimes people will have no issues getting pregnant even into their late 30s or early 40s. But on average, our fertility starts to decline once we hit our mid 30s. So that's one piece of it. And then obviously that also presumes that you have a partner that has a normal sperm count, because 1 in 3 couples that come in for care actually have a male factor. And so, that can be another component to that. So definitely need your partner to do a semen analysis as well and kind of get on the same page, and, kind of demonstrate that there's nothing else that's going on there. So not necessarily, but, sometimes people get frustrated with these less, kind of these less aggressive treatment options that have lower success rates. And so then when you're thinking about IVF, very important to look at where you go in terms of the success rates, because there's a very broad spread from place to place. Like, for example, in Houston, if you look at success rates, there's probably a 30% spread in terms of success rates in different clinics across the city. And so really important to do that research. It's public information that's put out by the CDC and the Society for Assisted Reproductive Technologies, which is called SART, S-A-R-T. Okay. If you just Google that, you'll find it. But if you think you might need IVF or egg freezing, let's say if you're approaching your mid 30s and you want to have kids later, but not right now, for both of those things, you need to do some research on the laboratory so that you actually go to the right place.
Okay. That was really, really informative. For anybody who asked a pregnancy related question, if we didn't answer it, just type it in the box below. I'm trying to scroll up and see everybody's, but some of them are getting a little lost in the thread. So just retype it so it pops up at the bottom. But I think that was really comprehensive in how it affects fertility and pregnancy. And how does PCOS affect menopause?
So, in that connection, actually, the nice thing is, and this is what like I think is probably one of the biggest silver linings, and I like to talk about, is that when we get to kind of the postmenopausal years for all women. So, like for example, for women that do not have PCOS, their risk of a lot of these metabolic issues that we've been talking about, diabetes, blood pressure, etc., goes up after menopause. And so, what it seems to be is that in general, if women that have PCOS are kind of going through our reproductive years with a slightly higher risk of some of these metabolic issues, by the time we hit menopause, in general, it seems like the risks for non-PCOS women seem to go up and kind of match that. And so, what we actually show in terms of end outcomes, like, mortality from heart attacks or strokes or things like that, it doesn't seem that PCOS kind of confers that risk later in life. In fact, what it really shows is that things that do at that point confer risk are having diabetes, blood pressure, obesity. And so to me, what that means is that if you can kind of control these metabolic issues through your premenopausal years, so, through your 20s, 30s, and 40s, such that you kind of hit your menopausal transition, average age 51, with optimal health or the best that you can achieve, then basically you're essentially negating, the impact of your PCOS at that point. And once you go into menopause, then, it's kind of irrelevant, honestly. So I think that the biggest postmenopausal impacts of PCOS are if, you haven't been able to kind of control, or you have just really severe situation or really severe case, and, you have had other diagnoses pop up along the way.
Got it. Got it. Okay. Okay. Super helpful. So one more pregnancy related question. Is it
Yeah.
safe to use metformin and or inositol during pregnancy?
So usually for most supplements at that point, especially things like that are most related to kind of getting you to ovulate, I would say you probably don't need it once you get pregnant.
Okay.
Metformin, I would say, it depends on why you were on it. If you were just on it to try to induce ovulation and your sugar levels are great, you probably don't need that either. But if you did have a history of prediabetes or something like that, then, it's definitely safe to continue in pregnancy, but you should really defer that question to your obstetrician. What I will say is that I do consider PCOS a risk factor for diabetes in pregnancy or gestational diabetes.
Mm.
And so typically for somebody that has no risk factors, you do a screening test for gestational diabetes in the second trimester, 24-ish, 25-ish weeks along into the pregnancy. However, okay, most of the people here are South Asian. And so many of us have a strong family history of diabetes. And by the way, again, this is all linked, so the fact that there's so much diabetes and, we gain our weight all here in the tummy area and have PCOS, these are all super related things and super related phenomena. And so, all of that kind of goes together. And so if you have that prediabetes stuff, or if you have that family history, those are all risk factors for having an early screen around 12 weeks of pregnancy. And so it's really important, if you have that diagnosis, I think, to advocate for yourself and ask your obstetrician if you qualify for an early diabetes screen. I don't myself have PCOS, but my mom has diabetes. And so I had to do that when I was pregnant. And, it's one more thing to do, but it's really important because you don't want to be, months late in getting diagnosed with gestational diabetes if that's something that, runs in your family or is in your personal health history.
Yeah, totally, totally. So just a little side note, can we do a brief primer for everybody on what exactly insulin resistance is and what it means? Because I'm not sure if that's fully understood.
Yeah. So it is kind of confusing. So insulin is the hormone that deals with the sugar that we get in our diet, regardless of where it comes from, whatever dietary sources. And so when we become resistant to insulin, which is something that women that have PCOS are predisposed to, so it's not a guarantee, but many women that have PCOS will become insulin resistant. What happens is that our body cannot process those sugars. It makes it easier for us to gain weight, harder to lose weight, and puts you at risk for other metabolic diseases. So again, gaining that abdominal fat, developing diabetes in pregnancy, developing type 2 diabetes down the line. So that's the risk factor. And that is true regardless of whether you have weight issues or not. So even women that are called lean PCOS, so like skinny women that have PCOS, still have a higher risk for type 2 diabetes than women in their same, body type that do not have a PCOS diagnosis. I think that's important to understand. So the screening should definitely be more aggressive than, for somebody that doesn't have PCOS. So again, if you have a gynecologist or a primary care doctor that, doesn't seem to be taking your PCOS seriously in the sense of, doing more regular testing for, things like elevated sugar levels, then, I think that's something to advocate for. Unfortunately, there's not a very clear-cut test for insulin resistance. So, there is kind of variation in how people manage that testing. But as I said, at the minimum, it's pretty easy to do that hemoglobin A1C test, which is just one blood test. I think a little bit more of a gold standard test would be the test that we do in pregnancy, which is actually where you drink a sugary beverage that has a specific amount in terms of grams of sugar in it, grams of glucose. And then you basically have your sugar levels tested to see, is your body able to handle that sugar load or not. Sometimes people will actually check insulin levels with that. The data on that is not that great in terms of that being effective, but some people prefer to do that. But really, we look at your sugar levels in the course of that. That's called a glucose challenge test. So that would be even one step beyond the hemoglobin A1C. But I would say that once you have that diagnosis of PCOS, it's pretty prudent to have that tested every couple years, and even more frequently if you have a sudden increase in your weight gain or other diagnoses that suggest that maybe your sugar level is getting out of control.
Yeah, totally. I like to think of insulin kind of like a key. So when you eat carbohydrates, your body breaks down those carbs into glucose, and then insulin is kind of like this key that goes to your cells and opens the door and is like, hey cells, hey glucose, come on into the cell. We got you. We're gonna keep you inside the cell. And it lets the glucose in to be used for energy. But when you're insulin resistant, those keys aren't working as well. So you have all this glucose, it can't get into your cells, so it's floating around the bloodstream, which basically means your blood sugar is getting higher, literally.
Yep.
And then your pancreas pumps out more insulin in response because it thinks things are not working. And then you get hungrier. Too much insulin also promotes fat storage. It inhibits lipolysis, fat mobilization. So, and then it also increases your androgen levels. And it's kind of this cycle of like insulin resistance, androgens, and all the things. So that's something that oftentimes why people say a lower carb diet can be beneficial for PCOS. That doesn't mean ketogenic or extremely, very low carb, but slightly reducing your current carb intake may help with women with PCOS.
Yeah, definitely. Breaking that cycle is really, really important because, like you said, it's a forward feeding circle, and it increases all of the manifestations of PCOS, no doubt.
Totally. So there are a lot of questions around hair loss in PCOS, both hair loss as well as excess hair growth. What would you suggest for those things?
Yeah. So, those are some of the trickier things to manage, honestly. So, when it comes to hair growth, so extrafacial or body hair, first of all, I always tell my patients, when we're looking at that, we have to compare that to, ethnicity based averages, right? So we have to I will say to my patients, compared to the average brown girl, do you feel like it's more, right? Because I can't compare you
We're
to
pretty hairy
somebody.
in general.
Yeah, exactly. We are. And that, that is known. And so, that is, but, usually people will laugh and be like, no, really, it is an issue. And again, what I was saying before is that it's not just, how much, because sometimes that may not be the issue, but also where. So sometimes people will say, actually I get this chin hair, or I have sideburn hair, or the way my, hair on my abdomen grows is kind of in this male pattern. So things like that can also show up. So, sure, sometimes again, if we get, weight under control, if we get ovulation happening, that will help reduce the effective level of those hormones and assist with those symptoms. If we go on birth control, as we discussed before, that will reduce the testosterone level, basically kind of, like I said, increases the available estrogen, and then B, induces these changes through liver enzymes to kind of suck up some of that free testosterone that's floating around, and prevent it from being active. And so birth control is very effective in that regard. On top of that, sometimes there's kind of a bevy of other pharmaceutical approaches that we can utilize. So spironolactone is a pretty common medication that's used for hair complaints. And that is actually a mild diuretic as well. So sometimes, there's some side effects from that. But it is also a teratogenic medication, meaning that it's unsafe to be on in pregnancy. So we almost always prescribe that with birth control. And the two things are synergistic. So they work really well together. Because their hair growth cycle is a 2 to 3 month, time frame, it does take at least that much time to see an impact. So it is something you have to take for a while to be, to be able to tell if it's having an impact or not. And then, beyond that, there are even more anti-androgen medications that are out there that a lot of times, dermatologists or other doctors might prescribe, that are all, like I said, anti-androgen medications to try to reduce that. Truthfully, when it comes to extra hair growth, many people will actually at this point, just turn to mechanical. I would say, more and more people are doing laser. The efficacy of laser hair removal for people really depends on the contrast between your skin and your hair. And so if you have really dark skin and really dark hair, then, it can be a little bit difficult to have effective laser therapy. There are also some lasers that are better than others for women that have darker skin complexion. So if you're considering laser hair removal, I would definitely ask, how are you going to plan my therapy based off of my complexion, and sort of, kind of make sure that they feel comfortable dealing with women of color. I have had laser hair removal myself, and I have always found that when I work with women of color, in terms of therapists, that they get that concern, and can sort of reassure me a little bit better, like, no, this is the right laser for you. And so, I think that's definitely, I think, something to keep in mind. The hair loss, that's a little bit more tricky. Some of the things that I've mentioned so far can definitely help. Lifestyle, stress management is a big one. Making sure you're eating properly. I've had patients have success also with, even your typical, kind of hair supplements and things like that, so biotin supplements and things like that. Unfortunately, it's a little bit of experimentation. I've had patients go down even more working with dermatology in terms of more severe things like injections and stuff that will help kind of rejuvenate hair growth. So there's a bevy of options, but oftentimes it's done in conjunction with a dermatologist.
Okay. Okay. Yeah. Someone specifically asked about scalp hair loss in women with PCOS. So would your suggestion to go see a dermatologist?
Yeah. So again, yeah, we see that, and oftentimes it's like in a male pattern. And so you can get it like kind of like a receding hairline almost kind of thing, or just overall thinning, or sometimes, at the top. So, people will say that there is actually a visual scale that sort of grades how severe the hair loss is. So yeah, that is something that can happen. And again, it is related to the high androgen levels, those high levels of testosterone, et cetera. And so trying to figure out how to drop those down can be part of that. But then again, thinking about all of the other things that just promote good hair growth in the first place. So making sure that, we're kind of thinking about those things also. And so that's kind of the combination, but there's not, again, like so much of what I'm saying, there's just not one magic silver bullet that works for everybody. It is one of those things that, does take some experimentation, and oftentimes multiple healthcare providers to find out the right thing that works for you. But I would definitely seek care sooner rather than later, because like I said, it does take some time to figure out what's going to work. And, it takes months for hair growth to kind of come back. And then you get this, little fuzzy baby hair that grows back.
Yeah.
And so, it's a whole process. So starting, I think, once you notice it, is probably better than letting it get really severe before you seek care.
Okay, that's a good tip. So we've talked a lot about weight management with PCOS, but what if you're not overweight? What do you do for clients who have the sort of thin PCOS phenotype?
Yeah, so I think totally, and then that is definitely a pretty common presentation. So it really depends what the symptoms are that are problematic, and that would be what I would focus on instead. Now, that being said, particularly among South Asian women, there is a whole epidemic of being an unhealthy thin, right? So and I'm sure you see that a lot too, Dee. So that could be South Asian people that are maybe have a totally normal or even underweight BMI, but what they're actually eating is not healthy food. So that's just kind of like genetics keeping them thin. But if you're not eating healthfully, then some of these other side effects and other symptoms that we're talking about might still creep in. And so some of that same stuff I'm talking about with regards to diet and all of that is not so much about a number on the scale, but is really about what you're actually putting into your body, and are you giving your body the right fuel it needs to be healthy. And so that it definitely is still a relevant discussion to have. So yeah, I think it's really actually not so different. It's just that the goals might be different in terms of how we would vocalize that, but I think the management is actually fairly similar.
Okay, got it. So still healthy eating, exercising regularly, sleep, stress management, the basics.
Yeah. And also if somebody's a skinny PCOS, but they're trying to get pregnant, this I would say is applicable to, women that are thin that are trying to get pregnant in any situation. Again, that's where I really focus on making sure you're getting enough healthy fats in your diet, enough substrate for that estrogen to grow, and sending your body the right message that you're in a fertile, situation. And so that's very important, for your body to perceive that your energy in, energy out balance is appropriate. It doesn't know that we're in 2021 and you could go get food at any time. It really just gauges what's going on in terms of your energy balance, in terms of regulating your menstrual cycle. And so it is really important to not necessarily lose weight. And so in terms of physical activity, again, kind of to your earlier point about how, HIIT style workouts aren't the best for everybody. That might be where, more strength training, trying to actually gain some weight or build some muscle mass is probably very helpful. And maybe for other kinds of workouts, doing more gentle things like yoga, etc., could be a better choice than like really intense cardio workouts.
Yeah, totally. So we're kind of nearing an hour. We're a little bit over an hour, so maybe we can take one or two more questions. One I think would be really helpful for people to hear the answer to is, do you recommend seeing a reproductive endocrinologist for PCOS or any other type of specific doctor? The woman who's asking this says that my OBGYN and PCP are super dismissive / have not offered this amount of information you've given in this session, which is great. But I hear this a lot from clients too, that OBGYNs, PCPs just tend to dismiss symptoms, are not very informative. How do you suggest getting support for PCOS?
Yeah, I do hear that a lot also. People are often like, wow, I've been dealing with this for 20 years. And, in 1 hour consult with you, I feel like I understood more than I understood in 20 years, which is really sad. I mean, that's why I love doing stuff like this, is so that, we can get that information to more people, hopefully earlier in their life. The reality is that many physicians are not well educated on PCOS. It is confusing. I mean, as you've heard me say multiple times throughout this, there's no one size fits all. It's confusing. It takes time to really discuss. And we know that even though I'm very proud to be a gynecologist and I have a lot of great colleagues that are gynecologists, I know that there is a history of kind of, downplaying a lot of what our lived experiences are as women. And so you absolutely have to have a healthcare team that hears you. And so I think that coming to see somebody like me, whether it's a reproductive endocrinologist, there are certain medical endocrinologists that really love to take care of non-fertility PCOS situations. And there are some, really talented gynecologists out there, primary care doctors that, that are interested in PCOS care. So it really has to be somebody that, is I think up to date on it and is interested. And when it comes to your gynecologist, if you feel like they're kind of blowing you off, one thing that I do suggest is that in your annual exam or your well woman exam, oftentimes you get 5, 10, 15 minutes and they literally have, I feel bad, honestly, for my colleagues in that situation. They have a litany of things to get through, plus your physical exam and your PAP if you're due for that and all of that. For me, I get an hour to sit and chit chat with people when I do a consult. So it's like a night and day difference. How could you possibly compare what you can get? So when it comes to your gynecologist, you can always ask if you feel like you're asking questions and they're trying to rush out the door. I would ask them if you can schedule a problem-based visit. That's like the terminology for it, at a later time. So that's a visit where you get, however long it is, half an hour or whatever, literally to just sit and talk. At that point, you don't need your physical exam. There's nothing else that needs to get done. And it's really about them listening to you and answering your questions. And that's one of my big suggestions that I give to people is, if you feel like you love your gynecologist, but you're not getting enough time to talk it through, then that's what I would do, is ask to reschedule a problem-based visit to talk about PCOS in more detail. And then you're going to find out how much information that they have and what can they actually tell you and refer you to. On top of that, again, also proud to be a physician, but we need, a whole team of people. And it's actually very clear in the most recent iteration of the international guidelines that an interdisciplinary team can really improve the care for women that have PCOS. So again, a fitness expert, a nutritionist, these are all things that can be really, really helpful. Support groups are great. PCOS Challenge is a large nonprofit organization I'm very proud to work with. Actually, our Efficacy Day for PCOS is on Thursday. And so, we'll be calling up, our senators and Congress people to kind of talk about PCOS. And, if you're interested in kind of meeting like-minded people, definitely join PCOS Challenge. I think it's a really great organization and I love working with them.
PCOS.
So, there's a lot of different things you kind of have to figure out what needs to be part of your team. If you, again, if you have mental health stuff that you're struggling with, you have a therapist, and things like that. So it's figuring out what you need and who's the right person. And I would love to say that, people should always come see a reproductive endocrinologist, but sometimes people don't have insurance coverage to come see us, which is a little crazy, but is a reality of our insurance situation in this country. So that tends to be one of the big barriers.
And are there any specific tests that people should advocate their doctors run? Specifically, this question was about when you get off birth control and you're trying to get regular cycles, but in general, what specific tests should people be advocating for?
So one thing before we end, I want to definitely encourage people. So in 2018, there was a very large effort, an international effort to create a new set of guidelines for management of PCOS. And those guidelines are fantastic. So if you are a science nerd, download the paper. I'll tell you in a second where to find it. That literally has the most detailed recommendations on what you should be asking for. However, this group, which included patient stakeholders, by the way, also created a bunch of patient-facing materials. So actually Monash University in Australia, so Monash, actually hosts the resources. So if you just even Google like Monash PCOS resources, you'll find it. And so there's a bunch of stuff that's like patient pamphlets and patient oriented stuff. And they actually even created an app that's called Ask PCOS. That's all like clinician validated stuff. So that's a cool resource that all came out of this effort. So you can go however into a deep rabbit hole you want to, but it talks about your sugar levels, your cholesterol levels, your blood pressure, measuring your actual waist to hip ratio, like you have an apple body type or a pear body type. It talks about all of that stuff and, how often you should be doing it. What are the reasons to be doing it more frequently, et cetera. So it's actually very detailed, but, yes, if you're having PCOS and you're in your 30s and you've never had any of these things checked, your cholesterol or sugar levels, etc., you definitely do for it.
Okay, awesome. I'm just looking at the chat. It looks like Grishma just popped that link in there. So awesome. I'll also send it out with the recording as well. So basically, check out that site for more targeted and specific advice for PCOS. Okay, great. Any last words, Rashmi, and any last bits of advice for women struggling to manage their PCOS, or maybe even a couple people here I know just got their diagnosis and they're just trying to navigate the world.
Yeah, I know. It's a lot, and so I would say two things. One is to validate that it is a lot, and a lot of times I will just say, like, it really sucks. Yeah, it's one extra thing, and nobody in life needs an extra thing, and so, I think it's important to validate that feeling and to feel that it's frustrating, to understand that it's frustrating, to understand that it would be great if there was just a cure, or, if there was a one size fits all, et cetera. So I think it's really important to validate that it is difficult, that it is frustrating. For me, I actually often even see teens that are, kind of diagnosed or maybe think that they do have PCOS. And, one of the things I will tell them is, look, I understand it's difficult to be in high school or college and feel like you can't just, do the normal things that, many of us have done at those ages and not, particularly paid attention to your lifestyle. However, on the flip side, you don't want to be, in my age range in your late 30s and, thinking like, gosh, I'm getting older. I really need to become healthy for the first time, right? You don't want to be in that situation. And so I try to tell people to view it as an impetus to hopefully think about your health in a better way, to establish better habits, in the beginning of your lifestyle, in the beginning of your life, earlier in your life, and to have that lifestyle from an earlier age, because you can reduce, the risk of all kinds of problems. And particularly for the South Asian individuals, if you look at our aunties around, I always say, like, think about those aunties, what you see when they're wearing saris, and like their body type, and like all of the diabetes and the blood pressure and the heart disease and everything that you see in our community. And that's not where you want to be in 30 years. And so, if anything, I would try to view it as your body's way of alerting you that you are at risk at an earlier age. And believe me, it's much better and much more effective to try to make lifestyle change when you're in your 20s and 30s than when you're in your 50s and 60s. And so, I think that's how I try to think of it. Like I said, if you kind of keep it under your control, through those reproductive years, it will kind of be less relevant once you are older. And so, that's how I try to think of it in a positive way. It's your body asking you for help. It's just a little bit of a journey to figure out, kind of what the right secret sauce is for you. So, that's kind of how I think about it.
Yeah, I think your mindset does play a big role here. And also just remember, you're not alone. The
Yes.
official stat is about 1 in 10 women have PCOS, but in the South Asian community, We were talking about this earlier. I don't think there's clear numbers around exactly the prevalence, but it's pretty high, kind of approaching 15, maybe even 20%. It's not 100% clear. And we're still figuring out why. But remember, you're not alone. This really affects a lot of women. I mean, think about how many people even just showed up to this presentation today, right? It's really common. Thankfully, there is more research coming out around it. There are a lot of good Instagram accounts. I know you mentioned your friend PCOS Diva.
Yeah.
Are there other Instagram accounts you'd recommend that are evidence-based and good quality for people to follow?
Yeah, I think, so I like a lot of her stuff. And the other resource that I direct people to is, and I don't actually know if she has an Instagram, but there is a registered dietitian up in Chicago named Angela Grossi. She has a couple books that have come out. The first one was the PCOS Nutrition Cookbook.
Okay.
And then her most recent book is is like a more holistic thing. And she even has a program that she's created now in conjunction with a mental health specialist. And so I love a lot of her work too, really evidence-based, really focused on food. And so, and eating healthfully. And I think that's really important and not necessarily part of our culture. And it's Angela Grossi, Grassi. And so, I think those are the folks that I often refer to in terms of like books and stuff like that. But, myself and many of my other fertility colleagues do a lot of PCOS kind of topics on our social media or in events like this. So, you can definitely look for that and find it on the internet.
Awesome. Well, thank you so much. How can people get in touch with you after this?
So I'm on Instagram. My content, sometimes I'm really good, sometimes I'm not, but I try to check it. My handle there is at @Kudesia. You can find me there. I'm on Facebook as well. I have a professional account. You can find me there too. And I will definitely try to keep an eye on my inbox, after this talk, but that's where I'm at. I practice in Houston. If you're in this area and you need help, definitely feel free to reach out. I can help you get scheduled and would love to help take care of you.
Yeah, thank you. Thank you so much. And if anybody is looking to start their health journey, we have a lot of free resources on the Boss Body Revolution. If you go to our website, bossbodyrevolution.com. Also check out our Instagram for a ton of tips. If you are looking for something more personalized, more custom, apply for our coaching program. We'll work with you one-to-one, give you a personalized plan, a lot of guidance, support, accountability to hopefully manage your PCOS symptoms and feel great in your body. So thank you everybody for coming. This is really informative, Rashmi. I know a lot of people are just even echoing that in the comments. So thank you so much.
Yeah, thank you for having me. This has been great. Thank you.
All right. Bye everyone. Good night.